Okay, so I think we'll get going. I know there's still some more people coming in, but we'll just do some of our introductions and people can join us as we go. So I'd like to welcome all of you, our guests, our speakers and attendees to this event, which just to remind you is being recorded. My name is Sheila Gilheeney and I'm the CEO of Alcohol Action Ireland. Now, this webinar marks the publication of a new report which uses data from the Global Burden of Disease study and highlights some of the impacts of alcohol on our health here in Ireland. And it also puts forward some possible policy responses. It has resulted from a collaboration between ourselves, Alcohol Action Ireland, and the School of Public Health at UCC, and it was supported by a grant from the Irish Research Council. The lead researcher on the paper is Dr. Zubair Kabir from UCC, and he'll be joining us from Cork to present the data and give some background to the GBD. He'll be followed by Doyle from the Health Research Board, who'll be talking about the work of the HRB in examining alcohol data. I know we were just saying earlier, I'm always so grateful to have the HRB reports, which really help us to make the case around the need for progressive alcohol policies. Then we'll be moving eastwards to Scotland to our colleagues from SHAP. That's the Scottish Health Action on Alcohol Problems. Lindsay Graham and Elinor Jayne will be presenting jointly on alcohol data in Scotland and how SHAP have used it in their advocacy, particularly around the introduction of minimum unit pricing. In the alcohol policy world, Scotland is very often our go-to place with a comparable sized population to Ireland and similar problems around alcohol. And I know we have learned an awful lot from the approaches in Scotland, and hopefully there's also some areas where we can share our experiences as well. We'll be concluding by having a panel discussion, and all our attendees, you're very welcome to put questions into the chat box and we'll do our best to get to them. So we'll get underway by introducing our first speaker, Dr. Zubair Kabir. Zubair is a trained public health doctor from India, and he's currently a senior lecturer at the School of Public Health in University College Cork, where he directs a multidisciplinary Masters of Health Public Health programme, and he is highly research active. He's the primary researcher from Ireland on the Global Burden of Disease study and has co-authored more than 50 high-impact journal publications, including in Lancet and Nature, through this global collaboration. Dr. Kabir has extensive experience also in tobacco control, and he's the founding editor-in-chief of the Tobacco Use Insights Journal since 2008. I know that many of us in alcohol policy look with great interest and, dare I say, envy at the progress in public health around tobacco control. So I think we'll be particularly interested to hear your insights, Zubair. So at this point, I'm going to hand over to you, Zubair, and let you get going. And I think you might want to share your screen. Thank you.
Good afternoon, everyone. Thank you, Sheila, for that kind introduction. As you see, the opening slide, this is the topic which I will be talking about. It's hard to disagree that we do not live in a world of uncertainty. And I hope the presentation today will have some relevance to this concept of uncertainty. So what I'll do briefly over the next 15 minutes, I'll go through two comprehensive reports which have been published recently, quote some statistics from there, and then try to go through some explanations of those statistics, and then have some final thoughts or remarks. The first report, as you see on the extreme right, is a comprehensive report published recently, last year, by the Health Research Board of Ireland. And we have colleagues in the audience from HRB, and also our next speaker, Ms. Doyle, was one of the co-authors of this comprehensive report. And then a few years ago, we have this landmark publication in the Lancet from the Global Burden of Disease team in 2018, which looked at the alcohol attributable burden across 195 countries. So moving on, the HRB report shows that in 2019, on average, the Irish people aged 15 and above drank 10.8 liters of pure alcohol. And this is the gold standard. And this is crucially important to be correct in the estimation process. We are not doing great on the global map. Ireland has the 9th highest per capita alcohol consumption rate across the OECD member countries. And it impacts on our healthcare system. As you see, more than 40,000 alcohol-related hospital discharges occur each year in Ireland. Finally, the same report estimated that in 2017, there were 1,094 deaths. So in other words, on average, there were 3 deaths per day in Ireland due to alcohol. And this corresponds to 4% of all deaths. And most of the deaths, they occur under 65 years of age, and which are considered to be the most productive age group. The same report, I quote 2 statements from the same report about these 2 key findings in terms of the per capita consumption and also the deaths. And they acknowledged that these 2 estimates are an underestimation. So we have to bear that in our mind. So moving on to the next comprehensive report published a few years earlier than the HRB report in 2018 is from the GBD 2016 study. This comprehensive report across 195 countries looked at the alcohol attributable burden by age, gender, location, time, globally, regionally, nationally, and locally. And they've used the same definition of who a current drinker is. But the key finding of this paper was that they concluded that there is no safe level for alcohol consumption at the population level. So it's important. They also suggested that we need to revisit our current alcohol control policies. This is similar to the secondhand smoke exposure, where there is no safe level of secondhand exposure. So GBD study, which was launched like 30 years ago in 1990, with a handful researchers across the globe. And since then, they have been publishing estimates on a regular basis. They started every 10 years, every 5 years. Now, over the past few years, we have annual estimates. So the GBD study of 2016 has some global statistics. There were close to 2.8 million deaths worldwide due to alcohol every year. And alcohol was ranked as the 7th leading risk factor for both premature death and disability. It's not just premature deaths, but also disability. But alcohol was the leading cause of death for the people who were most productive. And closer to home, I quote 2 estimates from the same report relevant to Irish population. The first one, as you see in the red, women in Ireland were ranked as the 7th highest consumers of average daily drinks. So there's a definition for what one standard drink means, which is equivalent to 10 grams of pure alcohol. And that stood at 3.1 for women in Ireland. And the second interesting finding was that they estimate that more than 2,700 deaths were attributable to alcohol. But you bear in mind that those are estimates, and they gave this 95% uncertainty interval. So these are all statistical inference at the population level. So the estimates can range anything between 1,500 to 3,200. So we see that these 2 estimates from 2 comprehensive reports published quite time to time have inaccurate or reliable estimates. So it's important for us to know which estimates are most accurate and reliable. But again, we have to bear in mind that we are comparing apples with oranges here. The data sources may be different. The estimation process or the whole statistical modeling are different. So it's all about measurements. So in the context of alcohol, these are the two key parameters which we should be right. First, how do you estimate the population level alcohol consumption? And once you have that correct, but this is the gold standard. The second estimation is dependent on the population level exposure. Once you have that, then we try to assess the risk outcome distribution curve. It's a distribution curve of alcohol and the health related outcomes. The GBD data are considered to be big data, and the 2016 study, as you see from this slide, they took into account more than 1,000 studies across the globe, across 195 countries. But the beauty of these GBD studies are, it's a global collaborative effort. Now there are close to 7,000 global collaborators across more than 150 countries. And the GBD team, they are based at the Institute for Health Metrics and Evaluation in Seattle at the University of Washington. So what we gather now is there is this necessity to have a systematic and rigorous approach to produce high quality population health evidence. So GBD does that. They try to compare apples with apples. They partnered with the Lancet in 1990. And since then, they have been publishing estimates across more than 200 countries by age, location, and year for more than 350 diseases and injuries and more than 80 risk factors, and alcohol is one of them. So GBD is a global enterprise. It's a flexible resource tool based on science through sincere collaboration for robust health measurements. And these data are publicly available. GBD is aware of the methodological challenges, but they use a standardized methodology, which is very important. Unless we have a standardized methodology and a standardized metric to harmonize the estimates, you cannot compare apples with apples. And the GBD has also solutions to those methodological challenges. Finally, how the comparability is based in GBD studies is through this standardized metric called DALYs. I won't go into details how DALYs are estimated, but GBD provides the quantification of health loss due to a specific condition. It's not whether you die prematurely, but you are living, how long are you living in perfect health? So DALYs is a combination of both premature mortality expressed in years of life lost and morbidity as years lived with disability. And the second component is about risk factors. How to estimate the burden due to risk factors, and alcohol is one of them, through this comparative risk assessment framework. So we took that into account for our recent estimation. We went into this GBD compare link where the data are publicly available and follow this comparative risk assessment to quantify DALYs and the deaths attributable to alcohol in Ireland for 2019. But there were new features to GBD 2019. As I mentioned, with each iterations, GBD may have access to more robust data, more strong epidemiological studies. For example, a recent systematic review has come up. So they take those into account. So likewise, in 2019, they had access to close to 500 new data sources, including data from Euromonitor, to account for the supply side estimates and also to remove compositional bias. And as I said, that to estimate the population level exposure of alcohol is the gold standard, they took into account 3 parameters. They factored into the proportion of abstinence drinkers, which is to the tune of 25%. They looked into the information related to tourism, how many of our Irish people go abroad and consume alcohol, and likewise, how many tourists come to Ireland and consume alcohol, which is to the tune of 2%, and then some unrecorded information, which may be due to illicit sales or home brewing, which is to the tune of 6%. So what GBD does with each iterations, the estimates become more robust, closer to truth, and the latest iterations supersede the previous iterations. So in the context of this findings of 2016, stating that there were 2,700 alcohol attributable deaths, they were rescaled to close to 1,500 alcohol attributable deaths in 2016. So based on that premise, we estimated that in 2019, in Ireland, there were 1,543 deaths due to alcohol. And as you see, there is a bound, 95% uncertainty interval. So it can range anything between 1,237 to 1,860. And that contributes almost 5% of all deaths in Ireland. And we rank them across disease conditions. As you see that most of the alcohol attributable deaths are cancers or digestive diseases, mainly liver. And these are the risk factor attributions, which are based on systematic review and meta-analysis. For instance, if you look at self-harm, it says 27%, which means that of the total deaths due to self-harm and suicide in Ireland, which is close to 400 for the year 2020, 27% of those can be attributable to alcohol. So assuming a causal relationship, if you eliminate alcohol consumption, then there will be 27% fewer deaths due to self-harm and suicide and in Ireland, so which is powerful. Finally, we estimated that there were more than 60,000 dailies lost due to alcohol. GBD uses powerful infographics and visualization tools. And here we see that the ranked disorders between time periods. So here, 1990, alcohol disorders were ranked at 13. 30 years after, they went up and ranked at 8. When we looked at the number of death rates per 100,000 population over these 30 years, the death rates peaked around 2,000, came down in recession, and in most recent years, we see that it's going up. And this nicely mimics the alcohol consumption patterns. They peaked around the same time period, 2001, hitting almost close to 15 liters per capita, came down during the recession, then post-recession went up, peaked around 2016, and now we see no change, stable, hitting at 10.8 liters per capita. And these are all related to affordability of alcohol. There were no sales tax in the beginning, sales tax was there, recession kicked in, and now we have very low sales tax. So on reflections, it's very sad that 4 people die of alcohol every day in Ireland. That's 5% of all deaths. We got to have good health data governance. And we must strive towards data which are timely, systematic, comprehensive, accurate, and most importantly, comparable. So if you can compare apples with apples through the standardized metrics such as DALYs, can assess the health performance, can benchmark our health performance in Ireland against our neighboring or comparable settings. So my final remark is, if you want to achieve better and robust estimates, you must make a sincere effort to work together to harness the data across the right stakeholders. I would like to acknowledge the Irish Research Council for the new Foundation Award, my colleagues at the Alcohol Action Ireland, and my student, Dr. Orla Cotter, who did all those preliminary analysis of GBD as a part of our MPH dissertation. Thank you for your attention.
Thanks very much for that, Zubair. And it is a very sobering note, I think, just that we end on. We think of 4 people dying today and another 4 people dying tomorrow. And I'm very conscious anytime I talk about deaths in this context. These are real lives, real people, individuals, families, really suffering, from something that we would just love to be able to reduce. And I think actually your presentation really brings that home. There's so many different illnesses that can be impacted or can be affected, and being able to reduce our overall consumption even just a bit does make a difference. I'm going to move on to our second speaker, Anne Doyle from the Health Research Board, and Anne is a research officer there. She focuses on alcohol research in her role, and that involves updating national alcohol surveillance figures and providing the Department of Health with information about the alcohol situation in Ireland in order to inform good decision making. I mentioned earlier our thanks to the HRB for their work on alcohol data, so I'm particularly pleased to welcome Anne and to hear more from her. She was one of the authors of the recent alcohol overview series, which Zubair had just mentioned, and we had previously been talking with Anne on our podcast series as well. So I'm delighted actually to see you here. I was going to say in person. It does feel like in person. We see the face, so that's even better. Okay, I'm going to hand over to you, Anne, and I think you might want to share your screen. Thank you.
Can you see that? Yep. Okay, so thank you very much for that, Sheila, and thank you very much to Alcohol Action Ireland for inviting me to speak to you today about the data that we hold in the Health Research Board, the alcohol-related data. We have data that's key in informing us about our alcohol use and the consequences of that use. So today I'm just going to give you a very brief outline of what we do in the Health Research Board, our national information systems, our national prevalence survey on drug and alcohol use, the alcohol overviews, the National Drugs Library, and then how we use this data. Are my slides moving on? Yes. Yep. So the Health Research Board, we are a state agency. We're under the Department of Health. We're broken down into 3 directorates, and today we're most interested in this one here, the Health Information and Evidence Directorate, which consists of the Evidence Centre and the National Health Information Systems. So it's those National Health Information Systems. There are national databases. We have 4 in-house, 3 of which are alcohol related. And I'm just mentioning there for your information, the 4th one on the bottom right there is National Ability Support System, a disability database that collects service use and needs of people with intellectual, physical or sensory disabilities as well as autism. But focusing on the other 3 databases then, firstly, the National Psychiatric Inpatient Reporting System. This is a database that collects all mental health disorders, but it's psychiatric units and hospitals admissions and discharges, including deaths. And what we're interested in today is the alcohol-related conditions. So this figure here shows the number of alcohol-related diagnoses as reported to that database. And you can see here that following the publication in 2006 of the mental health strategy, there was quite a decrease in the number of alcohol-related conditions recorded on that database. This was because as part of that strategy, alcohol-related conditions were recommended that they were treated in outpatient settings in the community rather than in psychiatric hospitals. But in fact, in 2020, the new mental health strategy has reversed that decision. And now if an individual has a dual diagnosis of a mental health condition as well as a substance dependency, it is recommended that they are treated in psychiatric units if that's the most appropriate setting. So we will certainly be keeping an eye on that data to see how it changes following that strategy publication. The next database is our National Drug Treatment Reporting System. This is a database that collects incidences of alcohol and drug treatment, so where an individual has received alcohol or drug treatment. And this figure here shows the number of cases of alcohol-related cases reported to that database annually. You can see it's remained fairly static over the years, with a drop off there in 2020, which reflects the COVID pandemic, and obviously a lot of services would have been closed, so we did expect that decrease. But again, we will watch that data to hopefully that more people do attend for treatment now that the services are opened again. We also then just looked at alcohol as an additional problem substance. So where an individual might have received treatment due to another substance, they can list other problematic substances, and this increases our alcohol-related treatment figures by up to about a third of cases. So it bumps up the figures considerably. We also have the National Drug-Related Deaths Index. This database collects all alcohol and drug-related deaths. It collects poisoning deaths, poisoning deaths would be the direct result of the toxic effects of drugs and or alcohol. It also collects non-poisoning deaths, and non-poisoning deaths are those where the individual had a history of alcohol dependency, or where the coroner has specifically implicated alcohol as being implicated in the death on the death certificate. And this figure here gives an indication of the number of deaths annually, the number of alcohol-related deaths that have been recorded on that database. And you can see that males significantly outnumber females. And it's been fairly static as well. As Zubair already mentioned, it's averaging on over 1,000 deaths annually. Our sister unit then is the Evidence Centre, and the Evidence Centre consists of an evidence team. This is a team of researchers who carry out evidence reviews on behalf of the Department of Health, and that can be on any health related topic. But what we're interested in today is the Drugs and Alcohol team, which includes the National Drugs Library as well. So one of our key roles in the National Drugs and Alcohol team is to carry out the Prevalence Survey. And this is a survey of drug, alcohol and tobacco prevalence patterns of use. It includes, or it has a representative sample of the general population. We also collect gambling activities as part of that survey. And you may have seen a couple of weeks ago, there was the gambling report was published, and it has a lot, it's very interesting to see because there's a lot of overlap with alcohol as well. So our Prevalence Survey has been undertaken 5 times, about every 4 years, and the most recent was published just last year. And that's an image of it there on the right. And some very top line findings from the most recent survey are that there has been a decrease in the number of drinkers aged 15 to 64. So we can go back to the very first survey. There was 84% of the adult population were drinkers. This has reduced slightly to 78% in the most recent survey. Another good news finding is that the median age for alcohol initiation among school children has increased. So back in 2002, your average 16-year-old had started drinking, and that's now, at 17 years. That's an increase now to 17 years in the most recent survey. So that school children are delaying alcohol initiation, which is certainly a welcome finding. However, we do remain a nation of hazardous and harmful drinkers, with binge drinking being quite common. 1/3 of drinkers typically consume 6 standard drinks per typical occasion. That is the official classification for binge drinking. And when we stratify that by gender, it increases to half of male drinkers would typically binge drink. Also, that survey reported that almost 15% of the adult population in Ireland would be classified as having an alcohol use disorder. And that corresponds to well over 500,000 adults, or 1 in 7 adults. And so that's quite a startling figure as well. We also carry out in the Health Research Board alcohol overviews, and these overviews would include all the data I've just mentioned, but also multiple other sources. It's basically a collation of as much information that we can get our hands on to look at alcohol use and its consequences. We can track trends over time and make international comparisons where possible. And the most recent of which there was, as Zubair mentioned earlier, it was published last year. And as Zubair mentioned already, these are just some top line findings from that. It's the level of alcohol that we're drinking. So into 2019, 10.8 litres, and as almost a quarter of the population don't drink, these figures are actually considerably higher. We're also 9th highest per capita drinkers, and we're 8th highest for our levels of binge drinking. We also looked at HYPE data. This is Hospital Inpatient Inquiry Scheme data, which looks at hospital discharges. And we requested the data on alcohol-related hospitalizations for the overview. And that found that over 40,000 discharges from hospitals were alcohol-related, almost annually, sorry, I should add, and almost 3,500 discharges for alcoholic liver disease. And of note as well was that the mean length of stay for alcohol-related conditions was 10 days as opposed to 6 days for non-alcohol-related conditions. So just an emphasis there on the level of costs basically to the hospitals as well, because they're a longer length and complicated to treat. So as well as the, I mentioned just briefly the National Drugs Library. Our National Drugs Library is a valuable and reliable source of information on substance use, and it's for anyone who has an interest or who's working or studying in the area of substance use. And it's funded by the Department of Health, and I've got a link to the website at the end, but it's an amazing resource that I'd encourage anyone to use. And so how we use this data, it is used to inform decision-making, policy, service delivery. It is used to monitor the impact of the Public Health Alcohol Act. It also would have been used as evidence to highlight how we need such legislation in Ireland. We also play a role in the National Drug Strategy, and we would regularly publish our data from the information systems and from the Prevalence Survey through bulletins, annual reports, papers, the alcohol overview, as I just mentioned. And we do requests for information, so an individual can request data from the systems for publications or for whatever use. It's also used for our HRB publication, the DrugNet Ireland. So finally, just to highlight that that's just a flavour of the valuable resources that we have in the Health Research Board. The data is open to researchers or to anyone basically with an interest or who's working or studying in the area. There's interactive tables for the treatment data available on the HRB library website, and the psychiatric treatment data is available on the CSO website, so you can manipulate the data yourself. And the deaths data, you would have to request it, but we really would encourage anyone who has an interest in it to request the data. It's there to be used, and we love to see it being used. And also, that was very much an overview of what we do in the Health Research Board, but it represents decades worth of data collection and thousands upon thousands of statistics. And as Sheila mentioned, every statistic represents a person whose life has been seriously impacted by alcohol use. And for every person, there's a family, there's a workplace, and there's a whole community that have been impacted by alcohol. And this data just gives you a flavour of the level of alcohol-related harms in Ireland. And we would encourage, it highlights the need for the remaining sections of the Public Health Alcohol Act to be commenced ASAP. So thank you very much. That was very brief, a whistle-stop tour of the Health Research Board, and I'm really happy to take any questions that you might have. Thank you.
Thanks very much. And there is just such a wealth of data and information, stored within that. And I know myself, like just how we frequently just turn to yourselves to get the data.
Right.
I see a question actually just came up, Marion Rackard actually there, and just talking about those differences in how we might measure deaths from alcohol, whereas previously we'd perhaps been talking about 3 deaths per day. And Zubair and the GBD data, which is modeling data, is suggesting it's more like 4 deaths a day. And probably no matter which we use, they're both awful. I think it's probably fair to say that the way in which we had been measuring, to date, we knew it to be an underestimate, because I think, as you would say, it was drawn very precisely. Things like certain conditions actually being actually named on the death certificate, things like that. And actually, there was a report out recently from ESL, also in collaboration with the Lancet. It's about liver disease, and they were looking right across Europe and said, gosh, the deaths in Ireland from around liver disease look low given the level of alcohol that is being consumed. So they sort of queried as well, gosh, there is a mismatch or an imbalance or something's there. So I think but we are maybe moving towards just finding another way of, or other ways I should say, of measuring that, and perhaps using that figure of 4 deaths per day. I hope it would make a difference. It shouldn't make a difference in one sense. It shouldn't be making a difference, but it is highlighting. And I think when I think about the deaths and the illnesses, I think an awful lot of people just don't realize the risk that there is from alcohol as a thing in itself, that they perhaps think it's somebody else who would be affected, and not maybe myself, that my drinking could actually harm this way. And I think as Zubair was pointing out from the GBD report back in 2016, that there simply was no safe level of drinking, and that's maybe just more the point that we need to be making. There is no safe level of drinking. And I suppose when we think about implementing the PHAA, we'd be thinking one of those things is putting health information labels on alcohol. Okay,
thank you, Sheila.
Not at all. Okay, and thanks a million for that. We'll move on to our third presentation this afternoon. We're actually going to move east, going over to Scotland, to our colleagues who are at the Scottish Health Action on Alcohol Problems, or SHAP. SHAP was set up in 2006 by the Medical Royal Colleges in Scotland, and I think is based within the Royal College of Physicians in Edinburgh. And I think it was set up really as a result of the concern from clinicians at the escalation in alcohol-related health damage in Scotland. It represents health professionals in Scotland, and it provides consistent expert advice and advocating for effective solutions to reduce alcohol-related harms. And I know that for any of us who are working in alcohol policy, you're one of those sets of people that we will often turn to, and we get very, very useful information from you there. So we have 2 speakers from SHAP today. We're going to begin with Dr. Lesley Graham. Lesley is a member of the steering group for SHAP. She is a retired public health doctor, and she was the public health lead for alcohol, drugs and health and justice for the Information Services Division of the National Service of Scotland. And I think that's now known as Public Health Scotland. She has worked extensively in the alcohol field in the areas of epidemiology, advocacy, policy and evaluation, as well as research both in Scotland and internationally. And she is a founding member of SHAP. And she'll be joined then by her colleague, Elinor Jayne. Elinor joined SHAP as director back last year in July 2021. She has a wealth of experience in influencing policy and representing organisations in Scotland and the UK. I know you've worked in a range of sectors and a number of issues, most recently headed up the influencing team at the healthcare charity Sue Ryder. And prior to that, she was with the Royal College of Nursing. So I'm going to hand over. I think, Elinor, you're going to share the slides to start with, but it's actually Lesley who'll be speaking first. Thanks very much.
Thanks very much, Sheila, and thanks also to Zubair and Anne for interesting presentations. So the organisation I used to work for is very similar to the one that Anne works for, and some of the data collection that we also do in Scotland is not dissimilar to what goes on in Ireland. But just a caveat to some of the statistics that I'll be talking through, they're not necessarily directly comparable to the Irish ones, and that's the point that Zubair was making, but they are not far off. But just a caveat there. So my first slide Eleanor's kindly going to operate the slideshow. This is a slide showing alcohol-specific deaths in Scotland over time. So those are deaths that are 100% attributable to Scotland. And you can see that around about the early 1990s, we start to see an upward trend happening. Now, in actual fact, at that moment in time, there weren't any alcohol-specific statistics being published in Scotland. We had no routine reporting. So we were sort of sleepwalking our way into this alcohol epidemic. However, around 2002, funding was granted, and my organisation was given money to set up an alcohol team, which I led on. And we began to publish specific alcohol statistics, including on a website. And those statistics have been acknowledged as being influential in driving the agenda, in particular for minimum unit pricing. Moving on to this next slide, there was also an influential paper published in The Lancet showing chronic liver disease mortality, which is known to be a marker of alcohol harm. And this slide is showing other European countries in the black line and demonstrating that Scotland, England and Wales were really out of step with the rest of Europe, and Scotland in particular. And this we call one of the scary graphs, and it was one that particularly caught the attention of the politicians at the time. Now, two key drivers we've already heard of alcohol consumption are availability and affordability. And both of those have been increasing in Scotland over this time. And this graph is showing affordability. So as the line goes up, that means alcohol is becoming more affordable, it's becoming cheaper. So you can particularly see that the top two lines are the off-trade. And we knew at the time that supermarkets in particular were, using alcohol as a loss leader to drive footfall. So moving on, in 2006-07, we established Scottish Health Action on Alcohol Problems. And one of the first things that we did, in fact I led on it, was to conduct a policy review. So drawing heavily from WHO and particularly no ordinary commodity, what are the most effective policies? What are the best buys? So we concluded that price was right up there as one of the best buys, and our initial manifesto called for stronger pricing policies. And around about this time, alcohol was increasingly being covered in the media. And then in 2007, the Scottish National Party win the election for the Scottish Parliament, albeit with the minority, but with the political will to tackle alcohol harms. So what did we do in SHAP? We decided to convene an expert workshop to look at price along the lines of a sort of parliamentary committee. So we heard evidence, including from the alcohol industry, and we conducted extensive background research ourselves. We also commissioned legal advice, both for Scottish law, but also European law. And we produced this report, Price Policy and Public Health, which was calling for the policy of minimum unit pricing as an alcohol policy, which is, as we know, is setting a floor price for a unit of alcohol. And as well as sort of proposing this policy, there was also a reframing of alcohol policy to a public health paradigm to be a population-based approach. And that contrasted, which was very prevalent at the time, with the industry approach, was that alcohol problems are just a small minority of people that drink too much. That's where we should concentrate our efforts. And quite honestly, that was also the preferred UK government policy approach as well. So this was a big shift in approach. So minimum unit price didn't really exist anywhere in the world, but that's not to say that the policy is not based on evidence. The evidence foundation that the policy is built on is the relationship between alcohol price, alcohol consumption, and harm. As the price of alcohol falls, consumption rises, and so does harm. And this is an old graph, but it's illustrating quite eloquently the relationship between consumption of alcohol and price. So the dark line, a very darker line, is price. As that goes down, consumption rises. So moving on to our next slide, 2008 to 11, 18 rather, sorry. So in 2009, the Scottish Government published a new strategy, the alcohol framework, with MUP in that framework. And just to point out that that framework, we're talking about evidence today and the importance of that, that had over 100 references, which for a strategy, I think is quite remarkable. We also made sure to build in that we would evaluate the alcohol strategy. So monitoring and evaluating Scotland's alcohol strategy is a programme of work called MISAS. So we built that in right at the beginning. And given that we didn't have sort of an evidence base as such, what we also did was commission the University of Sheffield to model econometric modelling of what MUP and other pricing policies could do. There was a very bumpy debate. The alcohol industry had suddenly sort of woken up to what was going on in Scotland. And at that point in time, I'd actually gone into the Scottish Government to work alongside the alcohol policy team. Now, because it was a minority government, the legislation did not pass at that time. But in 2011, the SNP were re-elected and we passed the legislation in 2012. Now, it had what's called a sunset clause, and that was the idea that was that after 5 years, we would hit the pause button, a comprehensive review would be done, and if the legislation hadn't been working, it would not continue on. So that was actually quite important to try and get that over the line. However, the Scottish Whisky Association took the Scottish Government to court. There was a lengthy battle all the way to Europe and back. However, in 2017, the Scottish Government won. The UK's Supreme Court ruled that MUP was legal, and it was implemented in Scotland in 2018. And just the next slide, please. So what's happened since? So in the 12 months since implementation, there's been a fall in alcohol consumption as measured by alcohol sales data, and this is per adult over 16, from 10.2 litres to 9.9. Alcohol-specific deaths, which I've been showing earlier on, they fell by 10%, reversing an upward trend from 2012. But along came COVID, disrupting all of our lives, but also reporting of routine statistics. However, we were able to report on consumption in 2020, which has fallen for a second year to 9.4 litres per adult. And there was a fall in alcohol-related hospital admissions, and that's including psychiatric admissions as well as admissions into acute hospitals. However, there was a 17% rise in alcohol-specific deaths in 2020. Now, it's plausible that those deaths are being driven by an increase in drinking in those already drinking heavily. And there are some sources that are pointing to that, but we've not got our big national surveys running at the moment. So just for me to conclude, despite early promising signs, I think we really probably need to wait for that MISAS report to make a full call on the effectiveness or not of minimum unit price, particularly in the context of COVID. I'm now going to hand over to Elinor Jayne for the rest of our session.
So just to conclude really and build on what Lesley was saying and conclude, we do know that it seems that the initial data that was collected after the introduction of minimum unit pricing in Scotland demonstrated that it was effective in reducing alcohol harms, but also, as Lesley said, COVID has driven a coach and horses through everything to do with alcohol, whether it's our consumption patterns, whether it is the provision of healthcare services for people with alcohol problems, or whether it is the actual collection of data in relation to alcohol. So now we really are in a difficult position in terms of interpreting that data. So after an initial good start, we are in a tricky position. So why it's important, this is why it's important that the Scottish Government doesn't just look at this data, but does use the expertise of others around it. One of them being clinicians who can interpret some of this data that sometimes maybe appears to conflict with each other. So for instance, the data that showed that alcohol-related hospital admissions went down whilst alcohol deaths caused entirely by alcohol went up at the same time. Clinicians can explain what was going on in the health service and how those deaths occur in order to give some context to that. So it's really important that all expertise is brought to the table in terms of interpreting this data. And what we also know is that in the real world, that data is a very important part of what's going to happen next with minimum unit pricing. The sunset clause that the Scottish Government now has to adhere to in terms of the legislation, which means it could fall, means that the Scottish Government does have to introduce to Parliament a very comprehensive business regulatory impact assessment, which will draw on all these various sources of data, all the MESAS data, other sources, and bring that all together in order to then put it before Parliament for scrutiny and then a vote on this flagship piece of legislation. So that's going to be a really important next step in terms of data, but it's also an opportunity for the alcohol industry to pick this data apart and try to use it to make the case for preventing the legislation from continuing. And we completely expect this. In SHAP's mind, ahead of the sunset clause, it would be really helpful if we're going to have an uplift or an uprating in the level of MUP from 50p to 65p to hopefully test just how effective the legislation is and to demonstrate how effective it is. So that, but anyway, now it seems that sadly time is against us because that sunset clause is actually in just over a year's time. So it seems unlikely that even if we do see an uprating in the level of MUP, that it's actually going to be taking place in time for any data to be used ahead of that vote. As an aside, interestingly, the industry itself is quite reluctant to share much of its sales data. So that's just an interesting aside, I think. In conclusion, I would argue that data is invaluable in helping us to identify problems and in terms of evaluating policy impact, as this case study has hopefully demonstrated, but it must be presented in a way that makes sense. It needs to be presented with policy solutions, and you need to build support with allies from wherever you can find them, basically inside and outside of politics. This is essential, particularly when you're going up against the heavily resourced alcohol industry that is often choosy with the facts and data that it uses. So you need to make the case at the right time, and also it does take quite a large dose of luck quite often in terms of your timing and what else is going on in the outside world. But all this, it's worth, it's our view that it's worth investing all this time and energy into this in terms of making the case for policies that are ultimately going to be worth taking forward if they're going to reduce the number of people suffering the multiple harms caused by alcohol.
Thanks very much for that, Elinor and Lindsay. And indeed, as you were saying, data is tricky. But one of the things actually, just coming back to the ideas around policy, very often when we start talking about alcohol, we're often met with this kind of fatalistic, it's Ireland, whatever, it's the culture, it's this, is that, the other. But actually, this is a problem with solutions. That there are other very big problems out there, climate change no matter, and other big things where solutions are quite difficult to find. But we're actually living in a world where we have evidence-based solutions. We can see controls around price, marketing, availability. They actually really do work. So I want to just maybe open up with our panel again. We've been talking a lot about the data, but the other part really of the title of our webinar today was, look, if we don't measure it, we can't manage it. So I just wanted to think about those ways of managing, and what else might be out there. And I'm aware I have the floor, so I'm going to hog it just for a moment and put forward something that we have been talking about, and we do mention it in this paper, this idea of the need for a state-sponsored office, a statutory state-sponsored office that would, if you like, take the lead both on policy development around alcohol, but that would be specifically focused on alcohol harm, on prevention, on treatment and care. Because I think at the moment we certainly feel that a lot of alcohol policies are spread across a range of different departments. We have licensing and justice, we have economic impacts, we have the Department of Finance who look at the tax base or whatever that. We have health who take this enormous chunk of their budget, over 10%, at least going on alcohol things. And yet where does the centre for driving alcohol policy actually lie? And I think there's a question mark there. So just throwing that out there, if anyone had any comments on that as maybe a way to go.
I've got to say, from a Scottish perspective, that would be great. We're in a slightly different situation in that some of the policy levers around alcohol rest in Westminster. So we have a sort of double, another complication to sort of throw into the mix, I guess, in that there's two legislatures that we need to deal with in Scotland. So, but yes, I think trying to have it a centralised approach and looking at it from a public health perspective would be the ideal scenario for us in Scotland.
Yes, indeed. I actually see a question coming up here from Angela King, who's just coming back to it, and Angela's just thanking you both for your presentation there, and she's wondering if we have similar data here around tracking affordability and availability of alcohol. So if I can just add a couple of things there, as Alcohol Action Ireland, we would have conducted an annual survey on price, where our specific thing was to look for where's the cheapest alcohol available, and we would have seen consistently that you could get very cheap alcohol very widely available. But the CSO would have data around alcohol, and actually just saw a very interesting piece of data from them last week. I just love the CSO. They have loads of data, and when you dig down deep into it. But it actually did give us a very nice graph on which tracked the average price of alcohol over the last couple of decades, and it is just incredible to see that how it has just gone down, and it got cheaper and cheaper and cheaper. So that's one particular place where you can look to find that if people are interested. Okay, and I think a decrease in license of off licenses, yes, and indeed. There is data actually within the HRB on off license, is that right?
There is some, yes, and we try and keep it updated from the revenue statistics that are available. Yeah, tried to cover that in the overview as well.
And I think that just it demonstrates just how many different aspects to alcohol that there is, because that the price of something, the availability of where you can get it, how much advertising we're exposed to. That's something that we haven't really discussed here, but it is. I mean, we certainly know there's very good evidence that would certainly show that for children who are exposed to alcohol advertising, they're much more likely to drink, and unfortunately much more likely to be drinking in a particularly harmful way. And I was struck on when you mentioned actually about the almost 15% of our population who would have an alcohol use disorder, but actually when you look at the younger population, so 15 to 24-year-old,
it's much higher. Yeah, it's 37% of 15 to 24-year-olds would be classified as having an alcohol use disorder. I think that's startling.
Yeah, it's an incredible figure, and I really think that tracks back to that level of alcohol marketing that we're exposed to. And of course that isn't just the advertisement you see on TV, though that is very important as well, and one of the reasons why we would certainly like to see the broadcast watershed for alcohol advertisements coming into play. But I think increasingly as well, so many of our children, and indeed ourselves, myself included, live your life online. So the amount of advertising that you see online is very much, and I think actually a very insidious form of marketing, because it is tailored directly to you, to your interest that you have in the palm of your hand. And also it's not as visible to others what you are actually seeing. At least when you're looking at TV, everybody sees it, and whoever's in the room sees and knows that's what you've seen. Whereas from a parenting point of view, you don't know what our children are actually seeing, and it's very I find that marketing too very, it's so engaging. You become part of the advertising. You're sharing it, you're playing games with it. It isn't as passive as just looking at something.
It's very clever, isn't it? Because, there's even types of drinks that are targeted at young girls, we'll say, or young boys. So you can see a difference in what young people are drinking. And there's been some research on it recently, but it's certainly an area we'd like to look into a little bit more, that kind of gender specific marketing for young people.
Yeah, I think, and as we often talk about a very clever industry, and we would have seen lower women drinking less than men, so therefore we would see this as an opening, as the industry, sorry, would see it as an opening, so there's a market there to be exploited. Zubair, you have your hand up there.
Yeah, thanks, Sheila. And also I want to draw some parallels, about tobacco control and alcohol control policies. And you alluded to that, Sheila, like there are a lot of commonalities, we can learn lessons from that. So tobacco control, if you go back in time 20 years ago, the same tactics were played by them as the alcohol big alcohol are playing these days. So why not, instead of reinventing the field, we can apply those best practices as Lesley mentioned, of WHO, and get a population level reduction. So it's more like a population approach, which Lesley again kind of hinted at, making more structural changes rather than going something like an individual agency type of approach, which may not be very cost effective. And so because of my experience in tobacco control, I think we can adapt a few of those policies and hopefully achieve that less than 9 liters per capita target, which is way back 2020. We are in 2022, so and a long way to go. Thank you.
And of course, like the huge difference between alcohol and tobacco, I suppose, is that framework convention, that we have this global convention, and that has driven, I think, the acceptability of making changes around tobacco. That is really, I suppose, something we would just love to see in an alcohol sense. And it really would help matters enormously. It's funny, actually, I received an email there just inviting me to a no smoking day, it's next Wednesday, and which is great. It's, it's a health initiative, excellent. And I thought to myself, gosh, imagine if we circulated a no drinking day, or no alcohol day. I just thought, oh my gosh, what would be the reaction? We accept the need for tobacco control, but we're just a little way off being able to accept that. And yet, when you ask people individually, we did some survey data, actually, just asking people about, their opinion on controls on advertising, and people are actually very happy. I've never met anyone who said, I wish I saw more alcohol advertising, so I think we should start where we can see that people actually do, and they do appreciate it, and that does make a difference. Okay. Well, I have tried my best to keep us on time. We're at just 4 minutes past 1 o'clock, but I was late starting, so I'll apologize for that. This has been very much a whistle-stop tour, and I'm very, very conscious that we had people coming and joining us from different parts of the country, and I'm aware that other people have other meetings and lunch or whatever to get to. So I'd like to just bring things to a close at the moment. I did put a link to the paper in the chat box, where you can find it on our website if you're looking to get that. It just really remains for me to thank all of our guests today, and to our audience, and to the IRC who funded us. And I particularly, though, would like to a very special word of mention to our intern student, Christina Kitt, who's actually at UCD, and she did absolutely Trojan work on the DVD data analysis, both for this paper and other research. Christina's in her final year in college, and we'll be watching with interest what she does next. I'll leave it there at that. Thank you indeed.
Thank you.
Thanks very much. Thank you, Sheila.